Great. Thanks so much for being here today with me. I'm Katie Murray. I'm a urologic oncologist, and I have a very specialized practice where I do a lot of urothelial cell carcinoma. And I'm here with GU Oncology now. And I have the special pleasure of sitting down and talking with one of my friends and somebody that I work with closely in our own practice here at NYU. And I will let Laura introduce herself.
I'm Laura. I'm a medical oncology GU nurse practitioner. I work really closely with Dr. Murray from the medical oncology side with the administration of mitomycin gel for our upper tract cancer patients, as well as in the advanced setting for our metastatic patients.
Sure. So I think this is a pretty exciting time, obviously, in urothelial carcinoma. And, we're in this era where collaboration obviously is extremely important and multidisciplinary care. We do that in tumor boards, we do it in our practices, but that's probably expanding even more to patients that are not just our metastatic patients, not just our advanced patients, but patients with earlier disease and potentially even low risk disease. So, Laura, over the past year or so, as we've kind of been collaborating on some of this and working more closely together, just talk me through your experience as a GU medical oncology nurse practitioner and kind of making that transition of taking care of patients with earlier stage disease.
Well, I think it's been really kind of an exciting addition to bring over to medical oncology because obviously we work together very closely with the advanced stage disease. So having a curable population has been a very nice addition to our day. And it's also kind of changed how many patients we have on the infusion floor. It's really increased the volume for the nurses down on the infusion floor, and it's made a much better, overall multidisciplinary team for the bladder cancer population as a whole. We've not only taken the mitomycin gel, but we've taken on some of the intravesical therapies. So we've had nurses be able to see everyone from early stage diagnosis to maybe later stage. So that's been a really nice transition, I think, for all of us.
Cool. I think this what we're doing, here at NYU is extremely unique and so I'm very proud of it. And I think the part that makes it very unique is oftentimes as urologists, alarm bells go off when we hear about saying we are going to ask medical oncology or infusion center to be of assistance for patients who have low grade disease or low risk or intermediate risk, urothelial cell carcinoma. And, I think you made some really good points that this is not, it expands your guys' practice. And what I would say then from the urology standpoint is, obviously as a surgeon, that's my priority and that's where a majority of my time goes. But it is helpful to have this true collaboration and multidisciplinary. And so I would say, this is not me giving up my patients or giving up this practice of these individuals and handing them over to medical oncology or the medical oncology nurse practitioners or infusion unit, because I really still am overseeing these patients and their treatment, right? I'm the one that diagnoses patients with upper tract disease. I do the biopsies, I do the initial discussion. They physically get their installations at the cancer center. And then I also follow them over time, right? And so, I have the luxury of working with Laura and her being a part of our team with this. So I think it's been really cool all around. So if we talk a little bit more specifically about upper tract urothelial carcinoma, and we've been using UGN 101 or mitomycin hydrogel technology for patients with low grade upper tract urothelial carcinoma. And obviously we do that for the most part through nephrostomy tubes for our installation. And of course, it's a low incidence cancer, but we have had a decent number of patients that we've been able to treat. So talk to me about your experience in that, because it is very different than an IV therapy and what that looks like and your part of working with the infusion nurses and how that physically goes for you guys as well as for the patient.
Yeah, well, we really kind of had to build this from the ground up, you and I. It's been a lot of collaborating to make sure that we had the treatment plan laid out and a lot of training programs for the nurses. So we've really kind of put them through. I think they have to do six watched over administrations of each with nursing educators and get signed off on before they're allowed to administer drug on their own. And in almost all of them, we have about two nurses for one mitomycin gel administration, just to make sure that everything goes correct. With the nephrostomy tube placement, we thankfully you at urology, you guys have been putting in the orders, so that's really streamlined how quick we're able to start drug. I would say by the time you refer a patient over and you've put in the referral for the nephrostomy tube, we usually start about 10 days later. So it's a really quick process. I've been very lucky with Perlmutter Cancer Center being able to get their hands on this drug really quick. And we have a really good working relationship with the reps there. So we always have enough drug on hand for everyone that they even hear about with, when you start diagnosing. And I think it's been an asset for the patients also to kind of have an added team watching over in case anything were to happen, because as you know, you're getting pulled in and out of the operating room all day. You have procedures in office. It's not always easy to oversee every single one. So I think that it's given us a lot more freedom and flexibility. Um, and as for the actual administration of each drug, we haven't had any drug loss, which I think is our number one victory. We haven't had one single vial, go unadministered, which is probably the first time they've heard of that. Yeah, that's huge. So we're pretty proud of that. And I would say all in all, the time spent with the nurses is only about 1 hour. They're in and out, and most of it is just allowing the gel to get here from pharmacy. They put it on ice for the 10 to 15 minutes, let it liquefy, and then they administer, and they actually keep them there a little bit longer just to monitor to make sure that there's no side effect right away. But we've been
Sure.
very fortunate and haven't had any.
Okay, great. Yeah, it's pretty impressive to see that, in a cancer center, and how you guys are doing that. And again, I'm just thankful that I have you guys obviously with me, and not against me. Not that anybody would ever be against one another as providers, but I think it's super important, And then the other thing I might say is, the patients get an extra provider, and then those extra relationships that the patient develops over time, over the 6 weeks course with, the infusion nursing and with yourself. And then I think probably my most exciting time in this disease specifically, when we've treated patients with UGN-101 or mitomycin hydrogel technology for low-grade upper tract urothelial carcinoma, is when I get to take the patients back to the operating room and look to see their responsiveness.
Yeah.
And I see amazing responses, or the last few patients I've had a very good response, and nothing is more exciting than me getting to send the message via the EMR, or when I see Laura in passing and tell her what an amazing response, that we had in this patient's upper tract, and we had, a complete response. And oftentimes, I think of my last patient, and they kept saying, make sure to tell Laura happy holidays. Make sure to tell her I said hello. I'm really going to miss everybody and seeing them each week. It was, some of the highlights of the last few months. So I think that in and of itself, a complete response with a short time period, but developing relationships with our patients makes this a super cool opportunity. So kind of going off of the upper tract, even though that's really our focus here, but anything that you foresee, even as you think of the infusion nursing or other nurse practitioners that you work with, and continuing to get people involved, or are people asking you questions about this, and where do you see this going in the next year, 2 years, maybe?
Well, we're already kind of working on expanding this because I think the volume that even we had anticipated when we first started this, we had projected only about 4 to 6 patients, and you came in with about 14. So we definitely have to figure out, how to continue to the training across board. We have a group of nurses who have expressed specific interest in this area. So I would say that there's a few who do most of these administrations, but we are working on still getting every single nurse on the 2 infusion floors that I have trained so that they're able to kind of handle the volume. Because I do anticipate that in the next 2 years, you're probably going to double that number, if not triple it. So we're kind of just making sure that we have everyone prepared for the increase in the volume.
Sure. That it's just super exciting. I'm so happy to have you here kind of chatting with me. And I really think this is looking into the future, and I can't express enough of how much this is, multidisciplinary care doesn't just mean having tumor board anymore. It actually is true multidisciplinary care where we're telling the same story across the board. They might see me this time, they might see Laura next time, even though I'm a urologist and work in urologic oncology and she works in medical oncology, right? That we really are truly on the same team. So I think that's super cool. Anything else that I'm missing, Laura, that I didn't say that you would love to share with any of our friends out here with GU Oncology now about upper tract urothelial carcinoma or our collaboration?
I would say that NYU is kind of setting a blueprint by having it be this kind of cross-disciplinary administration. And I would hope that, other hospitals maybe see this as a model that they'd like to emulate in the future. I think it has been really good for patient care. I have a lot of really good patient reviews who respond on Pres Ganey's that they're very happy with the nursing care. And I think that it's been a comfort for them to feel like not only do they have the medical oncology team, but you're so involved because you and I are usually in constant contact about these patients anyway. So that's really added an element of comfort to them that I think, isn't always attainable when you're by yourself. So I think that it would be nice to see other hospitals maybe pick up this model. That would be kind of my hope for the future here.
All right, great. Well, so happy to be here and glad that I got to be a part maybe of expanding your knowledge in an earlier stage disease and making an impact on patients' lives. Because although upper tract urothelial is a rare disease, sometimes as urologists and now GU medical oncologists, it doesn't feel so rare, meaning it feels like these patients do show up in our practices.
Definitely.
Great.
Thanks for having me.
Okay. Yeah, thanks so much. Bye-bye.